Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Emgality. Emgality is a drug approved in September 2018 for the prevention of migraine headaches. Not for the treatment of migraine headaches, but for the prevention of migraine headaches. It's appropriate for people who have at least 4 migraine headache days per month. If you have between 4 and 14, we call that episodic migraine. If you have 15 or more headache days a month, we call that chronic migraine. Remember, this is a preventive treatment. It is not for acute migraine. Now, if you look at migraine overall, migraine is a pretty common disorder. About 38 million people suffer from the condition. About a third of the people have such frequency that they would be candidates for some kind of preventive therapy, but only about 10 or 15% of the people at the present time receive the preventive therapy. And of the people who receive the traditional therapy, the traditional preventive therapy, more than half of them are going to discontinue therapy during the first 6 months. We've known about a chemical known as CGRP, calcitonin gene-related peptide. It seems to play a central role in development of migraine headaches. Now, this chemical is widely distributed in the brain and the body. We've known about it since about the 1980s. It acts as a neurotransmitter. It causes dilation of the blood vessels, and it's a mediator of something called neurogenic inflammation. So if we take a syringe with CGRP and inject it into a person who has a history of migraine, they'll develop migraine. On the other hand, if we inject it into somebody without a migraine, without a history of migraine, nothing seems to happen. So let's look at some studies. So episodic migraine first, between 4 and 14 migraine headache days a month. Trial mostly women, mostly Caucasian, average age about 40. In order to get into the study, you had to have at least 2 migraine attacks per month for at least 3 months. Average actually was considerably more. They screened about 1,700 people to come up with 850 people who were randomized into the study. The study required the correct frequency of the headaches. Headache had to last at least 30 minutes, had to have at least 2 of 4 features: one-sided headache, pulsatile quality, moderate to severe intensity, and pain that was worsened with physical activity. And they also had to have at least one other traditional sign of migraine, so either nausea or vomiting and or sensitivity to light and or sound. About 60% had previously been on some kind of preventive therapy, but if the patient failed 3 or more preventive therapies, they were excluded from the treatment. No other preventive therapy was allowed during the course of the treatment. But if a person developed an acute migraine, they could take the standard kind of therapies with the triptans, the sumatriptan or drugs like that, or the ergot preparations, or the NSAIDs drug like naproxen. Any kind of preventive therapy they were taking was stopped. They were followed for a period of about a month to get a baseline to see how many migraine headaches they developed. Then they were followed for 6 months during therapy, and then for a little while after therapy. Now, you always have to be suspicious when the drug company that is manufacturing the drug actually does the study. Well, in this case, Eli Lilly did the study. They were responsible for the study. They funded it, they conceived it, they designed it, they acquired the data, they interpreted the data, and they did the statistical analysis and presented their findings in a medical journal called JAMA Neurology in September of 2018. The study had 6 authors. 4 of them were employees of the drug company. Even though this is a very common disorder, the study was performed in 90 different sites in North America. 90 different sites. Well, let's look at the reduction in the migraine headaches, the drug versus placebo. Patients started out on average, they had about 9 migraine headache days a month. With therapy, that number was reduced by about 4 or 5. So at the end, the patient still had about 4 or 5 migraine headache days a month. With the therapy, with placebo, they reduced the number of migraine headache days by about 2 or 3. So overall, during the course of the entire month, what was the benefit of the therapy? The benefit was a reduction of between 16 and 30 hours during the entire month when the patient was freed of their migraine headache, the difference between the drug and the placebo. If we look at people who were completely prevented from having a migraine headache during the study, was only 11%, a smidgen more than 10%, so about 1 in 10, 1 in 9, 1 in 10 people, compared to about 6% of the people receiving placebo didn't have any migraine headache. Well, another study was done, and it was presented in a journal called Cephalgia, this time 6 authors, 3 of whom were from Eli Lilly, but they required 109 different sites in Mexico and Taiwan and Korea and Argentina and Czech Republic, including the United States and the United Kingdom, of course, and again, mostly women, mostly Caucasians. Average was more than 9 migraine headache days a month. Same number of patients as in the former study, pretty much. And if we look at the results pretty much consistent. We find that about 40% of the people didn't respond to the drug at all. And we find about 16% of them had complete freedom from migraine headache during the course of the therapy. And if we look at the benefit with regard to reduction in the need for acute therapy, well, it was only reduced by about 3.5 or 4 days in the people receiving the drug versus about 2-day reduction in people receiving the placebo. If you take the drug and you don't show marked improvement in the first month or 2, you probably aren't going to see any significant improvement with the drug and probably ought to stop it. Let's look at chronic migraine. So 15 or more headache days a month. And again, pretty much the same demographics. So these people, though, had about 16 migraine headache days a month. And with the therapy, they reduced that from 19 by about 4.5 to 5 days, reduced it by that much. So they still had about 14 migraine headache days a month on therapy. They reduced it by only about 2.7 days in the group receiving the placebo. If we look at the more than 50% reduction in the number of migraine headache days a month on therapy, well, about 25% were that improved. About 15% were that improved regarding a placebo. And if we look at the percentage of people who were more than 75% better, there wasn't any difference between the Emgality and the placebo. And again, there's not all that much difference in the reduction in the number of days when they need the acute treatment. Well, how's the medicine given? It's given, first dose is a loading dose, so you get 2 shots at the same time. 2 shots at the same time, different sites, and then every month you get 1 shot. And for ease, it comes in a pre-filled syringe, simple protocol to inject yourself. You keep the medicine in the refrigerator, you don't freeze it, you take it out of the refrigerator about 30 minutes before you inject it. You don't warm it in warm water or in a microwave. And if you're traveling, the good news is you can keep it out of the refrigerator for about 7 days, but you have to keep it below 86 degrees. It gets above 86 degrees summertime, you got to throw it out. Don't expose it to sunlight. Medicine is actually manufactured in Chinese hamster ovary cells with recombinant DNA technology, and the medicine itself is simply a type of gamma globulin. Once it's injected, it reaches the peak concentration in the body in about 5 days. The elimination half-life is about a month. And it's metabolized just the same as any other antibody, so it's not dependent on the liver or the kidney function, and it doesn't interact with any other kind of drug. Because it's so new, we don't have any information regarding carcinogenicity or mutagenicity or the impact on fertility, but there's no reason to believe that any of those issues would be a problem. And the side effects are relatively minor and limited mostly to a little mild reaction at the site of the injection, a little redness, soreness, or pain at the site. Some people develop vertigo or dizziness. Some people complain of constipation. Rarely a hypersensitivity reaction will develop. A rash or hives or swelling of the lips or the tongue or the throat. It could occur right at the time, or it could be delayed for several days. And somewhere around 5 to 10% of the people are going to develop antibodies to the medicine. So that's antibodies to the antibody, which is the medicine. So theoretically, that could prevent the medicine from working, but at least so far, it doesn't appear that that's the case. The medicine's clear and colorless. It's meant for subcutaneous injection into otherwise normal skin. So if you have a rash or if you have some redness at the site, pick a different site. It's injected pretty much the same way as insulin into the front of the thigh or around the belly or in the upper outer quadrant of the arm. There haven't been any head-to-head trials of these various monoclonal antibody drugs that are relatively new to the market. They all seem to work about the same. They reduce the number of migraine headache days per month compared to placebo by an additional 1.5 or 2 days. The medicines are well tolerated. They're convenient to use because they're injected just once a month. They don't seem to interact with any other kind of medicine. We don't really know about their long-term safety, but one issue potentially has been raised, and that's, remember that chemical, the CGRP, acts as a vasodilator? Well, what happens if your vessels go into spasm? What happens if you have angina or a heart attack or a stroke or hypertension? Could this kind of drug actually precipitate problems? Well, it's possible. It hasn't been studied very carefully or for a very long period of time. It's important to realize that we don't have any medicine to reverse the activity, to reverse a problem if a problem develops. Well, is there a place in our armamentarium for these drugs? Sure. Sure. For people who have severe, debilitating migraine headaches and who are not benefited by our other kind of less expensive therapies, then this drug might work. Or if the person has significant problem adhering to schedules of taking the pills, or for people who are taking an awful lot of pills and now adding a pill might add a side effect. There's a tendency to believe that the newer drugs are better drugs, but actually editorials in both the New England Journal of Medicine and the Journal of the American Medical Association, now simply called JAMA, suggest that these drugs aren't all that different from the currently available drugs, just a lot more expensive. There are patients who should not receive these drugs. Those are people who only infrequently develop migraine headaches, acute migraine headaches, women who are pregnant, and people who have either active coronary vascular disease or people who are at risk for acute vascular disease. In the family, at the present time, there are 3 drugs. First drug approved in May of 2018 was Amovig. Then in early September, Ajovy. And then in late September, Emgality. Well, Emgality, Lilly, currently negotiating with a variety of insurance companies and pharmacy benefit managers to see if they can get a heads up as far as the formularies are concerned, because after all, when the doctor writes a prescription, the likelihood of your getting the prescription if the drug isn't on formulary is relatively low. These drugs are expensive. The monthly list price, according to the drug company, is about $575. So the cost to you, if you go over to the drugstore and buy the medicine, is going to be considerably more, except now the drug companies play the game, so they have copay cards, and you can get the copay card, so you'll have less out-of-pocket cash, and the insurance company just has to pay the rest, or the negotiated price. So are the drugs good? Are they a major advance? They're okay. There's nothing you can say that's really great about the drugs, but they are expensive. And the benefit of the drug is relatively unimpressive. Well, if you want some more information about migraine headaches, you might want to consider watching my other videos, one on Ajovy, one on Amovig, another one on migraine headaches. There are a lot more videos we've done. So why don't you subscribe and see what you can learn. Thanks for watching. I'm Dr. Ken Landau.